think rather than do the roll call through Derek, I think if we introduce ourselves, that'll help people identify each other. Just say what your locus is on the board. So I'm Councillor Sarah Duncan and I'm chair of the IJB. Luann, next.
Yeah, hi, Luann Grujon, Vice Chair of the IJB.
John?
John Tomlinson, so I'm an NHS member on the IJB and I chair the RAP committee.
Okay, Alan Gray?
Alan Gray, I'm an NHS Grampian IJB board member and I'm also the Director of Transit NHS Grampian. Thank you.
Okay, Kim? Marco? Kim here? Maybe she's having issues. Right. Jill Al-Samurai, we'll come back to Kim.
Hi, I'm Councillor Jill Al-Samurai. I am Aberdeen City Councillor and board member for the IJB.
Okay, and Leslie Dunbar.
Hi, I'm Councillor Leslie Dunbar. I chair the Clinical and Care Governance Committee for the IJB.
Okay. Councillor Philip Bell.
Councillor Philip Bell, elected member for Lower Deeside and a member of this IJB board.
And then Howard.
Howard Gamble, I'm the service user rep on the IJB.
Jenny Gibb.
Hi, I'm Jenny Gibb. I'm the professional nurse advisor on the board.
John Forsyth.
Hi, I'm John Forsyth. I'm the legal advisor to the board today.
Okay. And is Kim Crittenden here?
Morning. Am I okay this time? Yes. I've got a very slow to react computer this morning. Sorry. I'm Kim Crittenden. I'm an NHS Grampian non-exec member.
Okay. And Maggie Hepburn.
Hi everyone, it's Maggie here. I'm the CEO of APCO, which is Aberdeen Third Sector Institute.
Okay, and Martin Allen.
Hi, Martin Allen. I'm business manager in the partnership.
Okay, and Sandra McLeod.
Hi, I'm Sandra McLeod. I'm Chief Officer for the Health and Social Care Partnership.
Okay, and Alison McLeod. No, maybe not. Alison Murray.
Hi, I'm Alison Murray. I'm a care rep.
Okay. Caroline Howarth.
Good morning, everyone. I'm Caroline Howarth, GP Clinical Director for Aberdeen City Health and Social Care Partnership.
Okay, and Chris Littlejohn.
Morning all. Chris Littlejohn, Deputy Director of Public Health.
Okay, and Gail Woodcock.
Morning everybody, Gail Woodcock, Transformation Lead for the Partnership.
Grace Milne.
Good morning everyone, it's Grace Milne, Development Officer for Performance and Strategy.
And Graham Simpson.
Good morning, I'm Graham Simpson, Chief Social Work Officer for Aberdeen City.
Okay, and I think the final person, but definitely not the least, is Derek Jameson.
Thank you very much for that, Chair. I'm Derek Jameson. I am clerk for the IJB and the Risk and Performance Committee, and hopefully here to assist and steer the meeting. I think the only one you maybe have is Alice McLeod, who did try to come in there, Chair.
Okay, that's fine. Alison, are you there? You able to come in?
Alex also joined us as well now.
Yes, hi. Sorry, did you not hear me the last time? I think I've got two microphones, so I need to remember to unmute both of them. So I'm Alison McLeod. I'm Lead Strategy and Performance Manager for the partnership.
Okay, morning, Alison. And Alex, Stephen, you here?
Yeah, sorry, apologies, a little bit late there, so but someone came up, but yeah, I am here.
Okay, great, thank you. Thank you for that, everybody. We're recording the meeting because it's a public meeting and the recording's already started. So I think the rules are that if you're not speaking and you're not the chair, then you can mute your microphone, please, and turn your camera off. But if you're speaking, if you could turn your camera on, that would be really helpful. Thank you. We'll take, so the agenda today has, first of all, are there any declarations of interest? Luann.
Yeah, Sarah, just to note, I'm a trustee of Aberdeen in Recovery, which gets funding from the Alcohol and Drug Partnership, but there's no decisions about funding today, so I will stay for that discussion.
Okay, that's noted. Thank you for that. I don't see any other hands up for declarations of interest. We don't have any private business, any exempt business today. So I'll move us on to the standing items. There was an additional circulation which has the minutes of the board meeting of the 11th of August and the minutes of the Risk Audit and Performance Systems Committee of the 26th of August. I'll just bring them up. Okay, we'll take the minutes of the last IJB on the 11th of August first. So I'll take it for accuracy. Page 3. Actually, we'll take accuracy and matters arising at the same time, if anybody's got any comments. So page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10. So we're happy to approve those minutes of the last meeting. Okay, great, thank you. And we've now got the Risk Audit and Performance Committee on the 26th of August. We'll take this next because it's in the same bundle rather than flipping back to Clinical and Care Governance just now. So these are for noting, but John, do you have any comments you'd like to make on this meeting?
Thank you, Chair. Really just to highlight that you'll see it was quite a busy meeting and we were able to catch up with a lot of the work. So I think now the committee is up to date, if you like. So it's from that committee plus what the IJB had transacted in the interim period. And we had a very useful reports on there. The business planners been clarified and rescheduled, and the duties report, we were able to look back and see how we had fulfilled the duties in the previous year and how they will be addressed in the coming year. And then you'll see substantive reports on audit, the strategic plan dashboard, the board assurance and escalation framework. So and then the risk register. So across the piece of what we're responsible for, we were assured that we brought things up to date. Thank you, Chair.
Okay, thank you. Does anybody have any comments on those minutes? Right, okay, we'll just note them then. Thank you for that, John. So we're now on to the Clinical and Care Governance Committee meeting that was held on the 28th of July. Again, these are for noting, but Leslie, do you have any comments you want to make?
I just think, similar to John, that this committee meeting really effectively gave us a catch up in terms of, you know, like some key reports that were there. There's a very detailed data monitoring report and also the COVID response to care homes. So I think we're also fairly caught up now.
Okay, that's good to hear. Does anybody have any comments on this? Jill?
Hello. I just wondered if the offer is still open for board members while we're doing virtual meetings to attend any of the subcommittee meetings. I wondered if the chair of the Clinical and Care Governance could confirm, or you could confirm as chair of the IJB, that, you know, we can seek an invitation to go and watch those if we aren't actually on the committee itself.
Yes, we did that before, and I actually attended the last Risk Audit and Performance Committee, so I think that's perfectly in order. I don't, either of the chairs have any comment on that?
I'd just be very pleased if people want to join. Yes, that's fine.
Okay.
And likewise for the Clinical and Care Governance, if Joe would like to attend, that's great.
Okay, that's good. Great. Thank you. Thank you for that. Okay, so we've noted the minutes of those two meetings. I'm very pleased that we seem to have caught up on the committee business. So that helps us manage everyone's workload, particularly officers' workload going forward. So we're now on to item 7, which is the business planner, I think. Hold on. Yes, business planner. So I think just as a kind of a linked item, you'll note that you all got sent an email by Grace on the 31st of August with the IJB planner as a whole up until next March, so which has board development sessions and workshops and the dates of the committees as well. So I think every board member should have received that, which gives you a full picture of the business, of the anticipated business of the IJB going forward. This business planner is the detailed business planner for the IJB meetings themselves. And we're still catching up on some work that we delayed through COVID. Is it Alex? So have you got any comment on this, Alex or Sandra?
I'll maybe just come in there, Chair. Yeah, so I think the planner is published. There's 4 reports that we're looking to delay in relation to. We're picking up, just starting to pick up again in terms of after our response to COVID. So there's 4 reports there that we're looking to delay, but all the other reports have been dealt with on the agenda.
Okay. I have just something to note actually. On page 10, there's repetition of items for the December meeting. I have to say, I had a bit of a heart palpitation when I saw the number of items in December and thought, oh my goodness, we're going to be here till the new year. But there's 4 repetitions. Items 38, 40, 42 and 44 are all repetitious items. And we're also recommending that items 41 and 44 be removed because they're being covered in other issues. That was the amendment to the standing orders to allow us to meet virtually. And that's been superseded by events and also the board governance paper that we've got today. So I would be suggesting that we remove the repetitions that I've said and that we also remove items 41 and 44 because they're already covered under other matters. Does anybody else have any comments or observations on the business planner? Jill.
Thanks very much. It's an observation at item 12 about the autism and action plan. I just wondered and see that the IJB board will see it by way of a service update, just seeking clarification that we will be able to ask questions if anything arises from that service update.
Yeah, it's going to clinical and care governance as well. So clinical and care governance would refer it through to the IJB if there's anything that is required.
Yeah, perfect. Thank you.
Any other comments or observations? Luann?
Thanks. Just to note for everyone that the plan on the page that's been circulated is a bit of a live document and there will be updates to that. So just, there may be an update coming out in a couple of weeks. It's not about taking things off. It's more likely we might add on additional topics, but we thought it was helpful just to get it out as soon as we could, but it's not a finished product by any means.
Okay, yeah, that's a good observation. Thank you for that. I'm putting you on the spot now, Alex, but the potential additional meeting in early October, if we haven't heard back from the Scottish Government, have there been any developments on that?
I've certainly not heard anything, but I was on holiday last week and I'm still going through some of the information, but I haven't heard anything about the timescales or anything officially around about that as it stands.
So just for board members' clarification, when would we have to make a decision to call that meeting? The papers need to go out the week before. So we haven't set a date, but it's potentially on the 11th of October. So we'd need to make a decision by the sort of 28th, 29th of September. Is that right?
An emergency meeting could be called at any time, Chair, depending when the timelines that are received by the Chief Financial Officer clearly were under their remit. So yeah, we would try to give the 7 days notice as much as we can.
Okay. Okay. I think it's helpful for people to understand that we may not be able to give the 7 days notice, but the chair, vice chair, and the chief finance officer and the chief officer and I will obviously meet and discuss this at the end of September if there haven't been any news from the Scottish Government on finance. And we will do our best to let you have 7 days notice, but it might well be that that's not possible. Okay. Right, so we've noted the business planner. Don't see any other hands up for that. And on to item 8, which is the Chief Officer's report. Sandra, over to you.
Okay, thank you, Chair. Just really, the report really highlights everything, just an update for everyone. I'm sure you've had opportunity to read it, but I did want to highlight a few key points. So just really the first one with regards to the locality empowerment groups, it's really, we're quite pleased to be able to say that we've continued to work with that, and I think there's been some good virtual sessions and some real progress made there. And also we are linking in quite firmly with them through Aberdeen Together with Aberdeen City Council, so there's a lot of joint work in progress around about locality empowerment groups. The care at home and supported living contract, that's been a significant piece of work and will be a significant piece of work as we continue forward with that. So to see that quite dynamic piece moving forward is quite heartening. But we will be aiming for the 1st of November, hopefully, to have our transition period in place. Another key bit I would just really like to highlight for board members is the family wellbeing, which we're part of. That's an initiative that's been led through Aberdeen City Council, which we're part of, and it's very much a real evidence of the partnership working that's moved forward with which will help support families and vulnerable children across there, but also really starting to embed the ethos of integration. And I think that's really should be really commended, the fact that that's progressing and that we're able to be in part of that. So I'm not sure if Graham might want to add something on that. Good to see as well, just to let people know about the community mental health, that we still are working forward on the transformation plan, so that's up there and there'll be a report coming in due course on that. And just finally, an acknowledgement that the winter plan has been submitted, and it really builds on the success of previous years, and also the COVID about our flow and links into our Operation Home First and the key areas that we have as a strategic board. I'm just happy to take any questions.
Thank you, Sandra. Right, John Tomlinson.
Okay, thank you, Chair. I really appreciate all the work that the officers are doing, and it's helpful to get these feedbacks as well. And we've seen both committees are right up to date, so I think that's a testament to the whole team. I'm just quite interested in the local groups and the engagement groups, and my understanding is we're also in touch and keeping going with likes of carers groups and the like, so that broadly we're keeping the momentum going across those contacts. I just wanted that confirmation around that. Would be helpful. Thanks.
Yeah, I can certainly start that, John, then I'll maybe ask Gail to come in just if there's just with a few more details. No, we've firmly made sure that we've built on all the work and all the experience with volunteers, our localities, and the momentum that's happened during COVID and pre-COVID. So a lot of work has gone into them, and not just ourselves, but absolutely through our partners as well. So I hand over to Gail if she's got anything to add, if that's okay.
Just really to build on that, so we have continued to engage with our locality empowerment groups and other groups and communities of interest, as you've said, John. So the COVID situation has provided an opportunity for us to really have a conversation about how we can best engage and support that engagement to take place. So that's continued predominantly through digital means, but that has continued during the COVID period, and we've been really pleased with the participation of a range of different people during that period.
Thank you for that.
Thank you, John. Leslie and then Maggie Hepburn.
Thanks, Chair. It's just a little bit more detail if you could tell us around the work that's ongoing with family wellbeing. I think building on the work that was done at Hubs, like that was set up as an emergency response with the COVID. And I'm particularly interested as well in terms of if it's the 3 hubs as I understand, but like how issues around maybe transport inequalities will be dealt with in terms of like families actually being able to reach the hubs.
So it certainly can come back on that, and I may well ask Graham Simpson, if he doesn't mind, to come in and add a bit. He definitely knows a lot more about this project, and I think it's actually one of the leads from ACC. So I think that with regards to the hubs and the progress that's been made, that this is about vulnerable families. So it is building on the work there, and it's building in the health, education, social work. It's pulling everything together into one area. But I'm going to pass over to Graham, if you like, because I think he's far more around this, and it is really, will be able to give you more information. Graham, if you don't mind.
Not at all, Sandra and Councillor Dunbar. Yes, I think the response during the COVID by setting up the 3 hubs has been very well received, and the feedback from families and the young people themselves has been really positive, but also from the staff as well, who have enjoyed just that much more collaborative way of working. So that the aim would be in the first instance to have the hubs in our areas of priorities across the city, and trying to identify locations which are accessible. Now, so clearly we would want to recognise that, but yes, there may well be at times transport issues, and we would have to look at how families and children access the hubs where that is required. I think we want to identify bespoke arrangements, and so some of the support the hubs may deliver may not be building based, it may be community based. So sometimes it'll be about taking the support to the family rather than the family coming to the support. And so it's about really thinking about what the needs of the family are, and how can we collaboratively come together to best meet those needs. Who's got the closest and best relationship with the family to affect change? It isn't always a social worker, it isn't always a health visitor, it isn't always a teacher, it could be any one of those, and it's about actually thinking about who is best placed to engage with that family to affect change where that is required, and support them. I think the other aspect of this is we need to ensure that these hubs have a very strong focus on anti-poverty. And really, we have built in strong relationships with money advice services, but also with the benefits agencies as well. They're keen to have a presence in those hubs. First, initially digitally, but then building that up to a real presence as COVID allows us to do. So these are really exciting. We would want to expand their reach over the course of time. But yes, start off relatively small at this point in time.
Okay, that's great. Thanks very much for your very full answer. Thank you.
Okay, Maggie and then Jill.
Hi. I was just actually following up on the family wellbeing centres as well, and I got quite a bit of my answer from that question of Leslie's, thanks. But it was also, perhaps if you're still there, Graham, it might be useful to hear what your thoughts are around participation and engagement with the third sector around the hubs, because it's quite new. The reason I'm asking is we're revitalising our fora at the moment in ACFO, and what we're trying to do is make sure that our learning from COVID reflects in what we're looking from our third sector to come to us with, so that we can actually engage with some of the learning from COVID from the statutory partners work. So with that in mind, there's a new mental health third sector forum on the go, and I'd really like to be as up to date as I can be about where they can get involved with all of the new developments in mental health that are happening. So if there's anything at all around third sector, that would be really useful.
We are, if it's okay with yourself, Chair, just in response to that we are keen to enter into a partnership with a third sector provider to help deliver those hubs, and I think actually providing that core family wellbeing service around that, and we are keen to move that forward, but also recognising that schools and others engage through PEF funding and other opportunities, a range of third sector organisations, whether that's Sport Aberdeen or indeed some third sector sector organisations directly. And again, over time, we would want to think about how we corral those interventions and actually try and get as much alignment to those to actually have the biggest impact as we possibly can. And so therefore, I think some of the relaxation of the PEF funding over the course of the pandemic has allowed us to begin to think about how we can do that. But certainly very much at the heart of this, Maggie, will be a family wellbeing service delivered by a third sector provider.
Okay, that all right, Maggie? Yep.
Sorry, I couldn't find my mic there. Yes, thanks very much, Graham. Really helpful. Thank you.
Okay. We've got Jill and John, your hand's still up. Do you want to come back in? No. Okay, Jill, over to you.
Thanks, Chair. Quite a lot of the questions have been answered in the responses that were given to John and Leslie's questions there. I've just got a quick question around about the mental health, pages 14, 15, around about how, I mean, noting that Sandra said that that it's been progressed. I just wonder how and when a report on how we're getting on with that is likely to come back. The other question that I had was on page 16 about the winter plan and accepting that the COVID is a kind of unknown demand, and we don't quite know what the demand might be. I just wanted to know how that might be reported back, if there was going to be any substantial changes that needed to be made ad hoc to the winter plan.
Sorry, I'll pick up the two things. I need to, the mental health and update paper is in the planner. I'm sorry, I can't recall and don't have the paper in front of me, but we'll get that checked out for you. There's definitely there, because the transformation programme is due to start on the 24th, I think, of September, if I recall correctly. Possibly not. So that's the whole programme that was agreed and in progress prior to that. So we'll definitely get reports back for you on that. With regards to the winter planning, I think there's a key focus this year on really trying to understand that we've got numerous different priorities. So in the past, what would happen is when we had surge in winter, we had the COVID, flu responses. What would normally happen is, particularly within our acute services, is that there would be a reduction in elective care, a step down of beds, a move to winter beds, and there would be surge capacity was created. I think there's very clear this year that from the directives of the mobilisation plans within NHS Grampian, which we've been part of and had feedback on, is that we very much need to make sure that elective care is continuing this year and that we can't continue to step down. The whole premise this year of moving forward with regards to there'll be additional beds for winter surge is not really on the agenda. It's much more about managing this in our community settings and managing this in areas whereby we have to focus on flow and definitely focus on capacity within the system. So I think as we're preparing into winter and as we're moving forward, the areas that we've been extremely mindful of is our community resilience. So if you recall that some of the planning that we've put in previously, working with, for example, the Aberdeen City Council being able to, and VSA, being able to access those very sheltered beds, we've maintained those, we're maintaining interim beds, looking at capacity there, but also just being really mindful of the data that's coming through and how that's progressing. I think as we go in, winter, somebody suggested yesterday we're not going to be able to outrun winter this year, but I'm not sure. I think we will have to be very flexible, very adaptable, and continue to monitor and manage each of the processes that we've been putting in. I think we're ahead in that we have the winter plan, we have Home First, we have the frail elderly pathway that's been looked at, we have things that we know have progressed really well from last year. We're building up on our care at home contract, we're building up on acute hospital at home. All of these things hopefully will be instrumental in helping us get through this winter, but definitely will remain agile, responsive, and reviewing the data as that comes forward. Does that help at all, Councillor Al-Samarrai?
Thank you very much for that answer. That's great. Thank you.
I mean, I think it's important to note that clinical and care governance and risk audit and performance are going to be looking at Operation Home First. And so a lot of the data from the winter plan will come through that. So we'll see it that way. if nothing else. And we're expecting a report back early next year on Operation Home First 2 once we're through the winter issues. And also the mental health strategy, it's item 36 on the business planner. It's due to come to the board on the 1st of December. So we'll get more update on it then. Okay, Luann, I see your hand.
Thanks, Sarah. It was just to follow up on that. When I was talking earlier about the plan on a page being a living document, that one of the areas that it might be useful to have included in a seminar this year would be the remobilisation plan that will be submitted, which includes our winter plan response. So I wonder if we could have something, once that's all formalised and signed off by the NHS board, if we had the remobilisation plan come into a seminar just so we can all understand it and what it means for managing surge over the winter period, that might be a helpful thing as well.
I can take that on board. Yeah, thank you.
Yeah, I think that's a very good suggestion. Yeah. Okay, I see no other hands for this item, so thank you for that, Sandra. It's a very comprehensive report, and the family wellbeing hubs are really exciting. It's proper early intervention and prevention, so I'd be really interested to hear back on how they are going. Right, we are now on item 9, which is the Board Development and Governance Contingency Plan. Who's going to speak to this?
It's myself, Chair, Martin.
Oh, morning, Martin.
Morning. Thank you, Chair. So the purpose of the report is to provide the board with an outlined development plan for the members of the board, as well as looking at proposals to be taken to ensure the continuity of the board governance matters if there's a requirement to revert to earlier phases of the government's route map for COVID-19. As mentioned before, the sessions that are appended in the report are outlined in the plan on the page that's been sent out to members last week, and these are based on discussions with board members at informal workshops and catch-ups earlier on this year. In terms of the continuity of governance, the report kind of proposes a few kind of ways in which we can continue to meet, I suppose, while we're living with COVID. So the examples being the greater use of Microsoft Teams, information bulletins, ensuring that matters of business are of strategic importance. And I suppose what we mean by that is as referenced in the board's business planner. And then as we move through the phases of the route map and learn to live with COVID, it's proposed that we try and retain the IGB's government arrangements as much as possible. But obviously, if there's a need to stop the committees, then we take that back to the board for consideration. The recommendations are before the board to approve the outline development plan and also approve the proposals to ensure continuity of governance matters. And I'm happy to take any questions.
Thank you, Martin. So any questions on this paper? No, unless everybody's got sticky buttons. Okay, that's fine. I think that speaks for itself. The paper's very clear, and we've had lots of discussions, both formally and informally, about what we need to do in terms of board development and making the best use of our time with Martha Simpson and her colleagues. So I think we'll just take the recommendations, if we may. Page 21. So we're approving the outline board development plan for IJB board members appended to the report, and approving the proposals to ensure continuity of governance matters if there's a requirement to revert to earlier phases of the route map for COVID-19. I would like to emphasise that we will do everything we can not to cancel committee meetings. We've only just caught up on business, and it would be difficult, I think, if we had to cancel committee meetings. But at least we know that the IJB is going to continue to meet virtually, even if COVID suddenly has a big uptick. So we're happy to approve those recommendations on page 21?
Agreed.
Yeah. Okay, that's great. Thank you. And thank you, Martin. Thank you. So item 10 is, I presume this is you again, Martin. It's the board record management plan. So over to you.
Yes, it is me again. Thanks, Chair. So the report presents the IGB with a draft records management plan and a number of appendices for onward submission to the National Records of Scotland. There's a specific act in 2014 which added integrated joint boards to the schedule of the act, so chief officers are therefore required to develop and submit a records management plan. So I suppose it's probably worth mentioning that the IGB doesn't actually manage many records at all, and in reality this amounts to a very small amount. But in order to formalise the arrangements between the IGB, what's been proposed is we would be following what ACC's records management processes are, and therefore a memorandum of understanding, which is outlined in Appendix E to the report, has been drafted and approved by the Council's Information Governance Group. This means that the records are held by the IGB rather than the Council for purposes of freedom of information legislation. And again, I think it's probably worth mentioning that again, the IGB don't receive many freedom of information requests. And if they do, there's a process in place in terms of the chief officer would prepare a response for consultation with the chair and vice chair of the board to approve. There's obviously a number of freedom of information requests that the partnership receive, but not specifically the IGB. And these freedom of information requests are dealt with through either the council or NHS Grampian route, depending on the subject matter. The recommendations in the report are asking that the board approve in principle the draft records management plan and the appendices, and the reason for that is I think it's just the scheduling of the council's information governance group meeting. They don't meet until the 14th of September. So recommendation B is asking to instruct the chief officer to finalise the plan and documents following that meeting, and then the final recommendation is asking the board to agree to forward the plan and documents to the National Record of Scotland by the required deadline of the 31st of October. Just by way of addition, which is not mentioned in the report, as part of the consultation, the IGB's data protection officer, who's NHS Grampian's head of information governance and data protection officer, has considered the plan and is supportive of the approach taken in the plan. He's happy that the IGB aligns with and takes assurance from Aberdeen City Council in respect of information governance. So I'm happy to take any questions on the report.
Thank you, Martin. Any questions on this? No, it's your lucky day, Martin. Oh, Luann, on you go. You're on mute, Luann.
Sorry, I was going to ask a question, but Martin has just answered it by saying NHS Grampian Information Governance have looked at this as well. So I'm very happy with the report as it is. Thank you.
Nobody else? All right, so we have 3 recommendations on page 29 and 30. We're approving in principle the draft records management plan and the associated documents. We're asking the chief officer to finalise the plan and documents after the City Council's Information Governance Group on the 14th of September. And we're agreeing to forward the plan and the documents to the National Records of Scotland by the 31st of October. So everybody's happy to approve that. Great, thank you. Thank you, Martin. Right, next item. Sorry, I have to scroll through a PDF to make sure I'm getting the right paper, so it takes a while. Right, item 11 is the annual report 2019-20. So Alison, over to you.
Thank you, Chair. So the report you have in front of you is in relation to the annual report for the IGB. The annual report relates to the last financial year. That's from April 2019 up to March 2020. It therefore relates to the first year of the current strategic plan, and it relates to activity mainly prior to COVID-19. Normally, what we do is we look at the national performance indicators, and we compare these to previous years, and we also benchmark across Scotland. Our colleagues who normally collate and sanitise and report that data for us have been diverted onto COVID-19 activity over the last few months, and we've been advised that that data, although there is data there, it's not robust enough to either be used for benchmarking purposes or to be published. So our proposal this year is that we publish the annual report as it stands, with space for 2 appendices to be added on at a later stage, which will contain that normal comparison and benchmarked data for both the national performance indicators and the MSG performance indicators. So what you have in this report is information that is related to the aims and the enablers in the strategic plan. And a lot of that information is based on the local survey that we did last September, which we have already reported to the IJB. So we've done an in-house design on this annual report this year, which will make it easier for us to be able to add in these appendices when they are ready. We are hoping to be able to bring the appendices back to the October meeting. That, however, is fully dependent on us getting the go-ahead that the data is robust enough to be published. But we're hopeful that we will get that in time for the October meeting, and we'll bring that back. And then the appendices can just be added into that report and republished. There has been discussion across Scotland amongst all the partnerships and IJBs around about how this year's annual report is going to be slightly different, and we have all agreed a sort of common approach with some common wording which reflects the change, and our report is in line with all of those discussions. So it's a statutory requirement for us to produce and publish this report, and we would normally bring it here for approval and then publish immediately, and also then send that on to our partners, to ACC and to NHS Grampian. So I think that's probably all I need to say about the report itself. Happy to take any questions.
Okay, any questions on this? John and Jill.
Yeah, and it's very welcome, the report, and it's very clear, and I do like the way that it's presented in terms of sharing pieces of work which relate to the different themes, and giving some data around that. I noticed that there is a theme coming through this about people wanting to get out more, page 81. They don't take part in community activities, page 80, and page 94, 73% of 60 to 69-year-olds talking about having no activities. So there's something sitting in there which presumably we're clocking and needing to pick up on. And just so just a question there in terms of how we are going to respond to that feedback. Excuse me, respond to that feedback. Thank you.
Yeah, absolutely. the survey itself gave us a lot of that information, and since we had the results of the survey and circulated that round the leadership team, we've been working on ideas as to how to improve some of those indicators for the next time that we measure them. So there's a few proposals and a lot of work ongoing to consider how to respond to some of that, some of those comments.
Okay, thanks. And I think for us as board members, receiving that, it helps us to then just join up the dots, if you like, between the project work, the feedback that we're getting, and then the impact on the strategic aims. So that as a way of presenting this and allowing us to get sight of it is welcome. Thank you.
Absolutely, and we're also, you'll recall that we're going to repeat the survey in 2022, asking the same questions. So that will be a test as to how successful or otherwise we've been at addressing some of those issues.
Okay, thank you. Chair, can I just ask one other question while I'm on? So it's about the publication of it, and I noticed it mentions that it would go up on the website. But there's some good information here, and in terms of what the partnership is doing and the IJB, and I'm just wondering if a more broadly based publication, and I mean I can envisage the local press or radio being keen to take whether the chief officer or other officers or a chair alongside this, so that it just seems an opportunity to promote the work and promote that dialogue with the public. I just wonder, get some comments on that.
Yeah, I think we've done, or particularly NHS Grampian has had some success recently with promoting some things like this around about using vlogs and you know, little video clips, and I wonder if there's perhaps scope for us to promote and launch, if you like, our annual report using a similar approach.
Yeah, well, I for one would encourage you to think about that. Yes, thank you.
Okay, Luann.
Yeah, thanks. It's following on from John's point, really. First of all, just I really like the report. It's very accessible, and I like how visual it is. If people haven't looked at it on page 80, there's a link, a barcode that takes you to a short film, which I think is excellent, and it gives a really good. It's about people who use our services, and it gives a really good idea of the diversity of the people in the city who use health and social care services. So it's really worth a look, not only because they talk very positively about the care and support they've received, but they also do give areas for improvement and suggestions. So it's a very good and engaging piece of work. And my question was really just about how we share that and how we can use the third sector to cascade this, as well as the routes that John suggested, because there's some good stories in there. Bringing it to life and having people understand what the partnership's all about. It's just a great document to do that with.
Yeah, so our third sector is represented on the strategic planning group, and the strategic planning group were involved in both in the development of this. The strategic planning group meets again on Wednesday, and the report is going back there for that very discussion about, so how do we promote this then? How do we get these good news stories out there and make sure everybody hears about the work that's been done? So that will be discussed at the group on Wednesday morning.
Great, thank you.
Okay, Alison Murray.
Sorry, it's just a very quick one. Someone's mentioning about it. It's very visual as a report, and it's lovely. I love the layout of it all. But I was just thinking from if you're a visual impairment point of view, I don't know how easily it could be read. That was it.
Yes, we had considered the accessibility of it, and what we're also planning to do is to provide a very much summarised version of it, just maybe on 2 pages, which will be just bullet points with in accessible font, etc. So that's another way that we can use to get the good news messages out.
Sorry, thanks, that's great.
Okay, thank you for all those questions. I don't see any other hands, so I had a quick question. Are we providing the partners with this version, or are we holding off providing it to them until we get the indicators added in, or are we going to give it to them twice?
So that's I guess that's up for decision today. I would suggest we probably want to hold off and give our partners the final version with the appendix.
Right. Do we have any views on that from board members? Agree. I've got an agree. Right. Okay. Yes, I think it's better to give them the final version whenever those indicators might be available. I think, though, given that the richness of this is in the narratives that you already have prepared, and it's in such a great format, I think we should be promoting it now, rather than waiting off, rather than holding off, because we're still not sure when those indicators are going to be available, and it might be into next year. So, and we can have 2 bites of the cherry. Politicians are great at that, multiply announcing things at the same time. So let's start getting the annual report out now, and then if we need to republish it later or do another round of promotion on it when we've got the indicators, that would be great.
Okay.
Okay. Let's see. So we have. So we're approving the report, and I think everybody is full of praise for it. I think it's an excellent piece of work. We're agreeing that it should be published on the partnership website. Do you want to publish the version on the website now without the indicators, and then we'll update it in the future?
Yes.
Maybe we should update the recommendation to make that clear. Okay. So Derek could amend the recommendation for that. That would be helpful. And we're going to present the approved annual performance report final version with the indicators included to Aberdeen City Council and NHS Grampian. So that recommendation needs to be amended. And we're going to bring forward the appendix containing the benchmark data when these are available. It says to the October meeting of the IJB or the soonest available meeting. Yeah. So we'll just tweak those 3 amendments if that's possible. Derek, do you want to come in?
Sarah,
Yes.
I think Howard was also looking to come in.
Sorry?
I think Howard was also looking to come in.
Ah, right. Okay. Derek, could we take Howard first? And
Certainly.
Yes. Howard, on you go.
It was really just to ask, are we aware how many members of the public actually look at this report? Do we have some way of measuring that?
So I think we can measure the hits on our on that particular page on our website, but I don't think we're able to tell whether that's members of the public or staff. So I'm not sure how we would be able to measure that.
Howard, do you want to come? Anything else to add?
Well, I think I felt looking at, I agree the report looks very nice, but it very much looks like something that would be done in hard copy. And I suppose if we are publishing it in hard copy, we'd have some idea of how many were going out to the public or whoever. And but we don't. So so I just have a concern about, do the public see this? Not really a criticism, but it's just a difficult thing to do. I appreciate that.
What we are planning on doing is using the information in the annual report as a basis to start looking at reviewing our strategic plan. and we're certainly planning to involve the public in that. And we're going to use the locality empowerment groups that we were discussing earlier on as a vehicle, and some of our other sort of special interest groups as well, as a vehicle to have those discussions. So we'd be starting from the data, some of the issues that John had raised, you know, that we had got from the survey, use that as a starting point for discussions as to what people would like to see in our next strategic plan. So I guess that in itself would be a way of ensuring that there was wider exposure of the annual report to the public.
Okay, thanks.
Okay, yeah, I think you putting it out initially through the legs would be a good idea. There's, I mean, 150 people have indicated an interest, and we're getting that's fantastic. Okay, I think Alison, your hand's up. Alison Murray.
Sorry, that's a mistake. Forgot to put it down.
All right. Okay, Derek, over to you.
Thanks for that, Chair. It's just following on from the recommendations which were suggested for that minor tweaking. May I suggest that if we are publishing it on the website and sending it to elsewhere, that we would be as well sharing it with the partners at this time and also in future once that data is further added, just to maintain the transparency and sharing protocols that exist.
Actually, yes, I see your point there, and yes, that's a good suggestion. So we'll provide them with the version now, and then we'll say when we provide it that we're going to provide an updated version with the appendices when the indicators are available. Okay, that's fine. Great. Okay, so we've got the recommendations on page 71 and 72, which we'll approve. Don't see any dissent on that. Right, excellent piece of work, Alison. Congratulations to you and your team for it in very trying circumstances. So I've always been kind of skeptical of the need for actual indicators, and I think this year might prove my point. Right, we're on to item 12, which is the Alcohol and Drugs Partnership Annual Report. Simon, over to you.
Good morning, everybody. The report that I've submitted is an update on progress made since last September, and it's trying to illustrate our ambition of having a whole system approach to alcohol and drugs that integrates into our public services and communities, but at the same time trying to reach and target and support the most at risk in our community. So during COVID, our ADP has continued working, our substance misuse services and third sector colleagues have continued providing services. We have adapted to help support the public protection agenda in relation to the harm caused by drugs and alcohol. We're more currently looking at Home First and the impact that drugs and alcohol are having on the emergency services. And you can see in the data that alcohol-related admissions to the emergency department continue to have an impact. And we're also trying to adapt our strategy to meet emergent needs. So we've been linking with Graham Simpson in relation to the family wellbeing hubs and looking to support that through some of our resource. There are 3 appendices. One is the timeline of work that has been undertaken during this period. Appendix 2 is the progress that we've made in relation to investment and recruitment, as well as the stretch that we have in relation to community planning and our improvement work. And Appendix 3 sets out the dashboard in terms of some of the data that we've been collecting during this period to help inform our work. So that's the report. There's a couple of recommendations, but happy to take any questions.
Thank you, Simon. Questions on this? Jill first.
Thanks, Sarah. Just a second till I get my notes here. Yeah, I think there is a kind of recurring theme through pages 120 through to 130 about things being or having to be reconsidered, and completely understand the circumstances for some of those comments. But there is a few areas where I would like a bit more clarity. If I could just start with item 3C on page 125, you know, obviously there's a comment that we should reconsider that investment, and you've said that sorry, apologies. I meant to talk about item 2D. Apologies. It's about alternative funding. You have said it's contained in the report, but I couldn't find it in the report. I just wondered if you could confirm to me where that funding is coming from, or whether or not it's coming out of a budget for the following year.
Okay, so that's 2D on page 120, is it? Which is the locality-based development worker. Is that right?
Yeah.
Yeah. Okay. Simon?
Yeah, so some of these projects we're reconsidering, either because we feel that they're not feasible to deliver the objective that we want, or that there's an emergent need. So, for example, the wellbeing hubs has been a clear sort of indication of a need, and it feels more sensible to invest funding into where there's a clear unmet need than to hang on to funding until COVID or other circumstances allow us to progress a project. So that's really the approach that we're trying to take, and we can provide further clarity or information on any developments and investments that we make going forward.
Jill, have you got more questions?
Thanks for that, Sarah. I mean, I'm guessing that the answer would be similar for some of the other questions, so I'll just ask my last question, if I may, and it's on page 129. It's item 5C. Now, I notice that the responsibility sits through obviously the CPP localities, the Health and Social Care Partnership, and ADP, and it was really just a question about whether or not everyone gets to decide whether or not that proposal is reconsidered, or if it's simply recommended by ADP and the other responsible parties accept it. If I could just get some clarity around about who's going to make the decision on whether or not that proposal's reconsidered.
Okay, so we've discussed that through the ADP, and ADP has community and community planning representation on it, and that was discussed and agreed as the most pragmatic way forward.
Thanks for that, Sarah.
Okay, thank you, Jill. I see Leslie and then John Tomlinson.
Hi, Simon. My question's really about some of the time I've spent during COVID is looking at Gabor Mate's theories, if you like, around addictions and dependency. So he's a former Canadian physician, for people that are maybe not familiar with his work. And essentially, you know, he has a theory that really the majority of addiction and prevention, the majority of addictions and dependencies are really responses to like early years trauma in people. And therefore, what I'm trying to ask is that, is the whole system approach that you're looking to, you know, like roll out further, really a way in which some early trauma or, you know, what we know often as adverse childhood experience. You know, like addressing really some of that.
Yep. So I mean, Gabor Mate's sort of research and work is sort of fundamental, I guess, across the whole of Scotland in terms of taking a trauma-informed approach to not just drugs and alcohol, but a whole range of trauma-informed services that help support people who have experienced adverse child events. There is a clear link between adult problematic alcohol and drug use and childhood trauma. And our strategy that we have been looking at is partly about trying to have a universal offering in terms of education and prevention, but also to have specific support available through one of the posts that we've created with Child and Family Social Work, which is a person to lead on working with the most vulnerable young people and care experienced young people. So all our strategies, our prevention strategies, are on the one hand trying to keep a universal offering, but also a targeted response to the most at risk, not just in terms of current drug use, but in terms of future years. So that's one of the points in terms of supporting the work that Graham is leading on in terms of the family wellbeing hubs, that there is this emergent need of young people being affected by parental mental health, domestic abuse, drugs and alcohol, etc. And I guess then the other challenge that we have is trying to make our universal services trauma-informed and sensitive to the needs of people with drug and alcohol issues who are often stigmatised and therefore find it difficult to engage with mainstream health and social care services.
Okay, thank you, Simon, for your very full answer.
Shall I come in, Chair? Yeah, thank you, Simon. The report's comprehensive and accessible, but in answering Councillor Dunbar's question, for me, I'd just like a bit more assurance on the way that we're making contact with people. There's reference to the use of video contacts, etc., being difficult in terms of digital and accessibility. I'm not sure whether that's access to the kit or access to being computer literate or whatever. And there was previous good street work, but presumably that's not possible in the current climate. And then you've mentioned the wellbeing hubs. I'd just like to be assured that we're changing tack in a way that we can be in contact with the client's base here, the people that we need to be in contact with.
Okay, so in terms of the first point that I picked up there in terms of the digital access, we've tried to balance, on the one hand, continuing to have appointments and front door services, providing some postal contact and home visits and delivery services. But it's fair to say that a great number of people who have serious drug and alcohol problems either don't have credit on phones or might not have a phone, or certainly don't have laptops and access. So there are national funds that allow us to access some technology to ensure that some people are able to get that. But I guess at the moment it's still a sort of emergent need about how we try and engage with the most vulnerable. And I do think that projects like the wellbeing hubs are an excellent way of trying to engage with people that way. In terms of the second point, I guess whilst we've had COVID, I guess our strategic aims haven't really changed. That on the one hand, we need a whole system response to drugs and alcohol, however it emerges in our public services, but we also need to prioritise and try and engage with the most vulnerable. And I suppose those challenges still stand irrespective of COVID. So I guess what's helped us do is focus and sharpen up some of our responses to trying to achieve our aim of reducing drug and alcohol related harm and in particular drug related deaths in the city.
Okay, just if I can come back just little bit on that. So from your point of view, are you assured that we're going to be able to make contact with people in the coming months in the way that you're reconfiguring this?
I think there are a lot of unknown questions. We have RAG scored and risk assessed every case that's currently open and prioritised the people at most risk. I think by joining together with the other public protection groups, so the Violence Against Women, Adult Protection and Child Protection groups, I think that there's a much more comprehensive and whole system approach to trying to work in relation to public protection. But I guess it's an unknown area, and not that I want to cause alarm, but I guess I guess I'm not sure that I can give that assurance that we are reaching the most vulnerable. There's obviously still people using substances in our community that we don't know about or aren't able to engage. So I think having a strategy that's flexible and responsive as much as possible is what we should be aiming to do.
Okay, so perhaps, I mean, that's a very clear and honest answer on that, but perhaps there's something for us in our recommendations to seek some further. That's not me, I don't think. Oh, right. I'm just thinking, Chair, maybe in an appropriate period of time, 6 months or whatever, it would be useful to have an update on this aspect of being able to get access. And I'm not questioning what Simon's saying. In fact, I'm welcoming that he's being clear about that. But I think it's an element of this plan that we should want to get some feedback on. Sorry,
Yeah,
Simon,
sorry.
did you catch what I was saying there?
Yeah, I get the gist of it. Sorry, there's workmen in the building here, and I've just asked them to pause for a second.
Yeah, I agree, John. And I think the assertive outreach work might help kind of provide some more assurance that the most vulnerable people in Aberdeen are being reached, and because it seems to me that they're in contact with services. They might just not be in contact with alcohol and drug services. And there was a really interesting report provided to community planning about the pilot, bringing the agencies together to look at that cohort of people. And I see that on page 111, it says that report's available to board members. And I would urge you to request it, because it is a fascinating piece of work, looking at the files of those people. So I think there's a role for your committee actually in looking maybe in 6 months and getting an update on the assertive outreach programme, on the joint work with the other public protection committees, to check on just how we are getting on with reshaping communication strategies with this really vulnerable group of people. If that's acceptable to you and to Simon, that's a sensible way forward.
I would certainly welcome that.
Are you all right with that, Simon? So
absolutely, I think that's very helpful and great. Yeah.
Okay, great. If people want to see the report on assertive outreach, if they could funnel requests through Derek, that's probably easier, and Derek can make sure that they're sent out, if that's okay. So rather than clogging up the chat just now, if Derek can kind of gather the data and send out the report, that would be really helpful.
Noted.
Okay, thank you, Derek. So Jill, your hand's still up. Is that a legacy hand, as somebody called us in another meeting, or have you got another question?
Indeed, apologies.
Okay, that's fine. I'm not sure about the term legacy hand, actually, but there you go. So I see Kim and then Luann next.
Hi, yeah, thanks for a very comprehensive report. There's so much data in here, it's making my head reel just a little bit. Some of the question I had was sort of asked by John, because looking at things like A&E attendances for alcohol and referrals to substance misuse, the figures are going down during COVID as we'd expect, but I suppose it's what's happening to these people. But I guess I was hoping that in some ways I could reflect on where we are against sort of other cities. I know it's very different demographics in other cities, but do other cities collect just the same data? Is there somewhere we can compare? I'm just very interested actually, generally in the picture. Are we seeing a similar picture?
there isn't a similar data set. This is something that we've developed locally. There was some data that's required through the Chief Officers Group. I don't have access to how other areas are recording or reporting that, but it's something I could follow up with. On a quarterly basis, there is a government-led ADP meeting where lead officers meet and sort of catch up and discuss how things are progressing, and there is one of those next week, so I would be able to get a bit of an update, but it would be anecdotal. The national published information, there's always at least a 12 to 18 month delay in some of the reporting, and that's the same with the drug-related deaths. We won't know formal data on drug-related deaths in 2019 until December this year. So the information that I'm providing is suspected drug-related deaths and is obviously quite sensitive in nature.
Okay, thank you, Kim. Thank you, Simon. Luann.
Thanks, Sarah. Firstly, just to thank Simon and the partnership. Clearly, huge amounts of work has been progressed over the last year, and that's really good to see. I think how we respond to alcohol and drugs is actually how we deliver our prevention and early intervention for the IJB. So it's a really key part of the activity for the IJB to consider. And I think the move to early intervention and whole system is absolutely the right way to go. So just want to say that and acknowledge that. I'm thinking about Jill's point about the changes in investment or where areas are being reconsidered, just so that we're clear, because the IJB has responsibility for this spend and that money comes through here. And at an earlier meeting, we have agreed these areas of spend. So for clarity today, are we saying we're content for that to be done at officer level? What's been suggested seems absolutely sensible to me, and it's very much in line with Home First and the IJB strategy. But I just think we need to be clear that that's a position, you know, the investment decisions, we're comfortable with those being taken by Simon and the ADP committee because they are still in line with our strategy. So I think that's kind of implied in the discussions today. So maybe it's a question more for Sarah to answer. Is that what we're kind of saying?
I think we need to have some views on that. I think if we're reprofiling the spend, then for transparency, I think a summary of the reprofile and how it's changed needs to go somewhere. And it probably needs to go to risk audit and performance. So we had approved expenditure a year ago under various headings. I'm happy for the officers and the ADP committee to make the decisions about the best way to spend it post-COVID, given the new landscape that everyone's working in, provided that it continues to focus on a whole system approach where possible and early intervention and prevention. But I think actually we do need to see the new decisions on spend versus the old decisions on spend, and they need to be reported back to RAP, I think. Are people content with that approach? Would that satisfy you, Luann, John?
That makes sense. I think it's just then clarity on it's coming back for information, if you like, rather than a decision at RAP.
Yeah, you're noting it really.
Yes. Okay.
And it's just to make sure that it's been transparent and there is a record somewhere of where the money is now being spent instead.
Yeah, agree.
Yeah, that's very simple, I think. So my next question, well, it's more for us to think about. It's great, all the data that's in the report, and it's very up to date, and it's good to see. Is that going to go through clinical care governance, you know, in terms of the data around numbers of, you know, more the sort of the profile of people as opposed to the spend, or you know, well, does that, who looks at that at the moment?
So our service data goes through the Health and Social Care Partnership governance process and structure. In terms of wider information, it was data that was requested through the Chief Officer Group, so it has been going there on a weekly basis, which is why we've adapted and changed it and developed this dashboard. So it goes weekly to Chief Officers Group and then submitted weekly to the government.
Okay, so the escalation process would come to the Clinical Care Governance Group, and if there were any concerns, it would then go to the committee. But it's hopefully all being dealt with operationally and not needing to be escalated. I'm just for clarity for us.
I'm happy to be advised by other colleagues and officers, but that's how things have been working in the last 6 or 7 months.
Yeah, I see Angela's put her hand up. So Angela, do you want to come in here?
Yeah, just to make this suggestion, it might be useful for Simon to bring just a bulletin paper back to the IGB for you to understand all the structures that are in place, because I think Luann's making a valid point. The IGB is here to hold to account, but there are a whole load of other partnership structures that are in place that equally the ADP is linked up to the CPP, and then of course the Chief Officer Group for Adult and Public Protection, and through COVID we've had quite a lot of attention on drug and alcohol as well. So I guess to get the balance between a whole load of extra work on officers versus getting the balance between appropriate scrutiny, I wonder, Sarah, if it's maybe just worth asking Simon to map that out for the committee so you can see all of the appropriate flows, because again I think it's about making sure that the right structures are looking at the right things and making a distinction between executive structures and structures for kind of public scrutiny. So it's great to see this agenda item here and the IGB given more attention to it, and I guess as a consequence always a risk of potential more duplication in some of the scrutiny. So I think it's maybe worth just asking Simon to bring a paper back for you to consider, but I just offered that as a suggestion, Sarah.
Yes, no, I think that's a very helpful suggestion. We found it really helpful when we were trying to get our heads around clinical and care governance issues to have the kind of organisational chart and the mapping of where different issues were escalated to. I think it also helps us all fix ADP in our minds as a partner and as something that we have some level of responsibility for, but not the entire responsibility. So I think it's appropriate that the spend, which is authorised through us, goes to risk audit and performance. But I think if you could, Simon, and actually the process of you pulling that report together might help clarify for you and colleagues where different issues have to be escalated to as well. And it gives you some assurance that you're not on your own when difficult decisions have to be made, or unhelpful or data that we might not want to see actually appears, which it probably will at some point. So if you're happy to talk to Sandra about a timescale for bringing that governance overview of ADP back, I'd be happy to have it.
Thank you. Yeah.
Thank you.
And Sarah, I had a final thing, and it's not a question, it's just really an ask that we put on record our appreciation of the work that services have been doing during COVID, and the innovation and the flexibility that's described in the report is really to be commended, even down to online yoga, which was noted there as being very popular. So just to note the IGB's thanks for all that work that's happened during COVID.
Thank you, that's appreciated.
Okay, yes, I think that's a very worthwhile comment. Kim, your hand's still up. Do you just want to come back in? No, maybe not. No, okay. Simon, thank you very much. And it's very comprehensive reports, and we look forward to seeing you again. You made huge progress in the last year. It's really good to see. Okay, so we have recommendations. So we're going to note the progress. It's page 105. We're going to note the progress of the ADP in delivering its stated remit and objectives. We're going to hold a workshop about drug and alcohol issues in the city and the work of the ADP. We need to identify a date for that. But we're also going to get a report back on the governance structures for the ADP at a future date. that date's to be determined based on workload and also IJB agenda. It won't be this year. We've got very full meetings this year. So we can add that in as a third recommendation to receive a report on the governance structures as well. Everybody content with that? Derek?
Fourth recommendation on the funding reprioritisations and diversions to go to RAP.
Yes, please. Thank you for that reminder. Yes, please. Okay, great. Thank you very much, Simon.
Thank you.
Right, I'm conscious of a desire to take a break after about an hour and a half. We have 2 items left. One is the report on MSG indicators and the other's on immunisations. So do people want to take a break or do they want to press on? Anybody? Right. I think I'd prefer to press on and see how we get on in 15-20 minutes time, if that's okay, rather than taking a 10-minute break now. So we'll take the MSG report next. Just bring it up. Right. Item 13, page 143. Alison, over to you.
Yes, thanks. So this report is in relation to the action plan that was created after we submitted our self-evaluation report in relation to the MSG report on progress against integration. We had 31 actions on that action plan. And 25 of them have been completed within the timescales. We were due to bring this report back in March of this year, but it was one of the reports that was deferred due to COVID. Some of the actions are still to be completed, and some of these are related to delays due to COVID. 2 of the outstanding actions are related to the revised scheme of governance, which will be presented to the IJB in December this year, and that will close those 2 off. One is related to public consultation on our annual performance report, and that was actually in relation to last year's report, but we've discussed obviously earlier in terms of our plans for consultation for this year's annual report. And the other outstanding actions were in relation to the carers reference groups, and we've discussed previously at IJB about the delay in relation to recruiting the IJB carers representatives and the knock-on effect that had to the creation of the reference groups. But we've picked that work back up again. So the report is basically just to as we promised, to give you a picture of how we have progressed with that action plan. The report is there for you, and I'll be happy to take any questions.
Right, thank you, Alison. Any questions on this? Jill.
Thanks, Chair. I thought this was a great report. It's got a lot of information, and I welcome the information in the progress update. I just had an apologies if it sounds like a daft question. At page 149, there's a section in the progress update that's highlighted in red font. I just wondered if there was some significance to that I'm missing. If I could just get some clarity around that point.
Sure, yeah, that's in relation to staff absence and turnover data. Basically, that information is something that we will be looking at on an ongoing basis. So I didn't want to put that into the report as a sort of snapshot, if you like, and I was waiting on some updates, particularly in relation to absence from the council side of things. So apologies that wasn't complete.
Thanks, Alison.
Okay, Howard.
Yeah, I'd come in on points 6.2 and 6.3, which are on page 156 and 157. You mentioned that rightly, that you've recruited the carer rep, and we haven't yet recruited a service user rep to replace myself. The comment I was really wanting to make was we've had a meeting with the two carer reps and Gordon Edgar to discuss how we do that, which is fine. One of the things I was a little surprised to find out from Gordon was that there had been discussion apparently in the early days of IJB of a service user reference group, which was a complete surprise to me really, because one of the problems I've had throughout really was quite who I was representing. And I think had there been a reference group during my period of office, I would have found that very helpful. So it doesn't really change anything, because I think the plan is to have such a group when we recruit new people. But I think it was a major gap during the years I've been on it, to be honest. And I was a bit surprised, given that I've occasionally muttered about who do I represent, that nobody ever actually mentioned the words service user reference group to me. So anyway, just a comment really.
Yeah, absolutely. I mean, the MSG action plan in particular raised the issues just in relation to carers, but absolutely, as you've mentioned, we're picking up that regular meeting with yourself and the two carers representatives and discussing how we can ensure that both yourself and the carers reps are representing as wide a range of service users and carers as we can. And as you know, we're discussing again linking in with the locality engagement groups. So we will pick that up going forward, Howard. You're absolutely right. I think in the when everything was set up initially, it was a bit difficult to cover everything. But I think now that we've had some learning from our first years, we know exactly what it is that we need to do. So we're committed in that group to ensuring that happens.
Thanks.
Right, John, I think.
Thank you. My question is just about the decision that we're going to be asked for here. So we're asked to, this is an update on progress, and we're being asked to note that. I'm just wondering, are we actually signing this off, given that we've completed so much, and then the other 6 items are, we can see how they're going to be progressed and to what sort of time scale. Are we not effectively signing this off and saying that's a complete piece of work, rather than just noting the update? And would that be a more helpful or clearer decision?
I think when this was when we were originally going to bring it in March, we had an expectation that the Scottish Government and MSG would come back to us and look for us to report to them and perhaps undertake another self-evaluation and start again, kind of thing. So but that hasn't happened. I don't know whether that was specifically about COVID or some other reason. So yeah, if the IJB is happy to accept that we've progressed as much as we can and will progress the outstanding actions, I'd be happy to change the recommendation to signing off the action plan.
Yeah, Sandra, I see your hand.
Hi, it's just a suggestion, just wondered if for completeness, if it is being signed off, should we return it to SG to advise that it has been covered off? Just so that closes the loop for us as an IJB, closes it for the paper, and then if we are asked, at least we're preemptive as opposed to.
Yeah, that had occurred to me as well, that we can demonstrate we've actually followed through on the actions that this MSG report required. So yes, I think that's a good idea. I think we should note the progress made on the delivery of actions, agree that the actions are completed or likely to be completed, and to send the final report to Scottish Government for their information, I think. And then we've closed it off, actually. It's interesting, there was such a lot of emphasis on this in 2019. There was such a lot of focus on this piece of work done by Audit Scotland and then the MSG follow-up, and it seems to have been completely dropped, which, I mean, you can understand that priorities change, particularly in a pandemic, but you'd like to think that somebody will pick it up, because there were a lot of IJBs that had a lot of recommendations that they needed to fulfill. I think it would be demonstrating yet again that we're ahead of the curve up here, which is always a good thing. Okay, we got any more comments on this? Derek?
Just a governance observation again, Chair. Given the high volume of stuff that has been closed off and that intention to report to Scottish Government, would it be better to report all the closed items to Scottish Government and retain the work still to be done to go to one of the reference committees, probably Risk and Audit, for future sign-off to indicate that that is complete, should Scottish Government come back to us at some time? So
after December, so the annual performance consultation's been done now. We will have done that. We'll have done the scheme of governance, and then there's the carer and service user focus group. So actually, it's probably only the carer and service user focus groups that need to come back. And we'll have a report on service user recruitment, won't we, coming to December's meeting? So yeah, okay. I think I'm not sure.
Defer to December's meeting to write this one off. When you've got the report.
I don't think it needs to go to Risk and Audit. I think we'll pick up the outstanding recommendations if there are any under the service user, the next service user recruitment paper. I think that's where we'll pick it up.
Thank you.
I'm aware I've given RAP an awful lot more extra work today. I don't really want to add even more in. Okay, right, that's fine. Thank you, Alison. Another excellent piece of work. And the final paper today is immunisations. So over to you, Gail.
Thank you, Chair. So this report brings an update to IJB on our immunisation plans, including the redesign of our immunisation service, our approach to delivering the vaccination transformation programme, and our plans for delivering mass vaccinations over the coming months. So as you'll all be aware, immunisation is one of the most effective public health interventions in the world for saving lives, and we can particularly see at this current time why it is so important and what can happen when we don't have effective vaccinations in place. So there's a number of drivers for the changes we've been progressing, and the changes we've been progressing have been ongoing for some time. So there is a commitment to reduce GP workload linked to the Primary Care Improvement Plan. We are seeking to improve immunisation uptake levels in Aberdeen, and the current processes we have around immunisation delivery isn't as person-centred as we would like. So we would want to change that so it is much more person-centred to make it as easy as possible for people to receive their important immunisations. So there's a number of different vaccination work streams. There's a preschool programme, the school-based programme, there's travel vaccinations and travel health advice, the flu programme, and at-risk and age group programmes, including a range of different vaccinations such as shingles, pneumococcal, etc. In addition to that, we're also planning for when there is a COVID vaccination, so we're ready to deploy that as quickly as possible to the population. So at the moment, the vaccination service has been delivered through a number of different teams. Some of the vaccinations were delivered through our general practice team, some vaccinations were delivered through the preschool team, and some through the school age team. So we're aiming to pull all of that together into a single team to use that skilled team as best possible to meet the peaks in demand as we go through the year. We're also looking to change where we're delivering vaccinations. Traditionally, they will be largely given in GP practice. Obviously, the current period, we're not looking to do that. So most of the routine immunisations will be delivered from a range of different community hubs. And again, they will be provided in our localities in locations which are close to and easy to access, so have car parking close to bus routes and a city centre location as well. We've also reached agreement with our education colleagues to deliver school age immunisations in the schools to, again, encourage that uptake and make it as easy as possible for as many school children as possible to receive the immunisation. And for our mass immunisations, that's flu and COVID when it's available, we'll be using a range of different community spaces, including sports halls, churches and other large venues. So we need to obviously allow for social distancing at the current time, so all of our plans take cognizance of providing safe vaccinations in an efficient way as possible for the people of Aberdeen. So in terms of planning for our flu vaccinations, on the 7th of August, the Scottish Government announced additional cohorts that will be included in the flu vaccinations for this year. So that includes all of those over the age of 55 and, subject to vaccine availability, all those over the age of 50. And all those identified as shielding and those living in a household with somebody identified as shielding. So we've calculated that's approximately everybody who will be entitled to flu vaccination in Aberdeen is approximately just under around about half the population of Aberdeen. So it's a fairly sizable cohort of people to provide vaccinations to. In terms of processes, it's really important that we get that flow working well, so we're able to provide the vaccinations safely, allowing for cleaning of vaccination stations, allowing for physical distancing to take place, to make sure that we're able to vaccinate people as quickly and efficiently as possible and as safely as possible. So that's really the content of the report. There's some more detail in there. I'm happy to take any questions that anybody might have.
Thank you, Gail. Questions from people? Philip.
Thank you, Chair. Thank you for the report, Gail. That was actually, it's obviously a very difficult subject. But I wonder, could I perhaps just have a few clarifications for some of the words in the report, which I don't fully understand, and maybe just look at some of the numbers as well, and the numbers of message you're proposing to actually do immunisations. So against the objectives on 3.6, it says that the model of delivery is going to be co-produced. So could you clarify what co-produced means? I know what co-produced means, but what does it actually mean in this context?
So when we've been looking at the previous models, what works well, what doesn't work so well, what would work better, we've spoken to groups of people who receive vaccinations and who need to take their family to receive vaccinations, for example, young mums, not necessarily young mums, but mums in general. And so we've heard from mums that what makes it difficult for them to receive vaccinations for their children is that sometimes they're given an appointment that might be during the working day, and they might have gone back to work, so that's quite difficult for them to take time off work. So we've listened to, we've engaged with users of the service basically to find out what would make it better for them to make it as easy as possible for them to receive the immunisation. And we've used that information, as well as the staff who deliver the service as well. We've used all of that information to try and develop a model, and that model is ongoing improving. What we're putting in place isn't the final polished version. There's a number of different steps we need to put in place, and we'll continue to use user feedback and staff feedback to continue to improve that.
So how is that co-produced? I don't quite follow that.
So the design of it is co-produced rather than the delivery of it, if that makes sense.
Okay. Thank you. So can I ask you about objective 2 then, sustainability? Sustainability of, so what's a sustainable vaccination program?
So a sustainable vaccination program in this context will be a vaccination program which is affordable within the financial envelope we have available. We have the staff that's available to deliver it, and it is designed in such a way that it's easy for people to receive the vaccination, so they're able to we're able to maintain our uptake levels and increase our uptake levels.
Okay, thank you. Can I ask 3.7 now, please? So 3.7 mentions that the current immunisation service will see a change from several disparate teams. So presumably by that you meant that there were several different teams all doing their own thing. There was no coordination. Is that what you mean?
So previously, the preschool vaccinations were delivered by the preschool immunisation team. We had a school-aged immunisation team delivering vaccinations in schools, and the adult vaccinations were delivered through GP practices. So there are a number of different teams. So it wasn't, they were all working to what was required, but we've identified it'd be much better in terms of achieving our objectives if there's a single team delivering that across the city.
Okay, so but by disparate, that almost implies there was no coordination. Is that the case?
So each of the vaccination programs was delivered, but it was delivered separately as opposed to being coordinated. So in terms of the peaks and troughs of deliveries throughout the year, different programs are delivered at different times. We weren't able to take advantage of that by having a single team because the teams worked independently.
Okay, thank you. And so may I please ask now about 3.13. So 3.13 says that additional nursing, coordination and administrative support brought in on a temporary basis during peak mass immunisation periods. Well, how do you know what those peak mass immunisation periods would be? How do you predict?
So basically, the most usual peak immunisation period is the flu period. So during the period from September through till December, January, we have to deliver all of our flu immunisations, and that happens every year. This year, as I've explained, there's an additional cohort which increases the numbers. So there's an intense period of immunisation during that 12 to 14 week period. In addition to that, this year we're anticipating there will be hopefully a COVID vaccination, which will be required to be delivered to almost all of the population. So that will be a mass, a peak period as well in terms of vaccination delivery. Other vaccinations are delivered on an ongoing basis throughout the year, but we do need increased staffing over a temporary period during that flu vaccination period and when we have the COVID vaccination.
Okay, but I mean, but really though, we are just really, you know, the big questions are getting the getting antibiotics out for the flu vaccine and also for COVID. So so I'm kind of struggling to see where this, you know, where this. I suppose you're considering that temporary because it's not going to be all year round as MMR. Okay. Could I please ask about 3.18 now? Okay, so this says that different cohorts will receive different types of vaccine. So this is presumably we're talking a cohort, so children with MMR, adults with flu, with COVID. Is that what you mean by that?
So this is in relation to the flu vaccination. So different cohorts, for example, school children receive a vaccination which is delivered nasally, and adults will receive a vaccination that's delivered through an injection. So different cohorts receive different vaccinations too, and also people with different allergies will receive different vaccinations as well. So it's to meet people's clinical needs. They do receive different vaccinations, and also in relation to the additional cohorts that have been announced by the Scottish Government, they will be phased as well, depending on vaccine availability. So it's all linked to sort of the availability and the flow of the vaccine being delivered, and then they need to be delivered to the people to receive the vaccines.
Really? So how do you know that I've got an allergy to anything? I'm just going to rock up to get my vaccination.
Your GP will be aware of that. It's all linked into the clinical system, so this happens every year to make sure that people get the right vaccination dependent on their situation.
Okay, and then my final question, please, which might possibly be a little bit lengthy. So this is actually related to 4.3. So this is actually just with regard numbers of immunisation nurses. So I'm just trying to get a handle on, you know, if you're looking at the right numbers of nurses, because clearly, you know, we've got a set period of time, we're just going to get this job done. So it was the audit meeting that we were at a little while ago. We were told 130,000 potential flu vaccinations. But today, in this report, we're being told potentially half the population of City. That's like 110,000. So is it 110,000 or is it 30?
So the financials in the table you've got in the report are based on the actual cohorts from last year, and we've only recently, obviously the announcement was earlier on in August in terms of the additional cohorts. We've also only recently got those figures, so there will be some shifting in that. We're working out the detail, but we've only just had the final figures in terms of the numbers of eligibility in Aberdeen City over the last week or so. So this is a constantly moving figure, and that's explained in the notes at the bottom of the table.
Okay, so constantly moving. So what period do you want to do the vaccinations over, you know, for flu?
So the flu vaccinations will start in October and take place over 12 to 14 weeks.
Right. So how do you arrive at 21 immunisation nurses?
So we've modelled how long it takes to give a vaccination with the staff required. So that 21 full-time equivalent over that shorter period, so that's a lot more than 21 staff, was based on the cohorts prior to the recent announcement. So we will need to rerun that modelling, and that's happening at the moment based on that additional data that we now have available.
Okay, well, we were told at our last audit meeting that 4 nurses can do 100 vaccinations in 2 hours. So is that the number you're going to put into your model?
So it's a very complex modelling process that this is going through. So I would provide assurance to the IJB that we are putting this through the robust modelling process we have in place to make sure that we have the right staff to deliver the vaccinations that are required.
But yeah, but surely you need, I mean, it's basic maths, so Gail. So if you know the number of people you're going to vaccinate, how long it's going to take, you can work out how many people need to do it in that time. So that should be quite straightforward. Sort of value, shouldn't it?
I think Gail has answered that by saying that the modelling is being rerun based on the new information of the new number of people that need to be vaccinated for flu.
Okay, I'm just, you see what I'm trying to guess at here, which I'm not at all happy with, is that 21 nurses can do all these numbers.
But it's not 21 nurses; it's 21 whole-time equivalents. And that's based on a whole year cost, but we're basically recruiting them for 4 months of the year. So it'll be an awful lot more than 21 people. And whole-time equivalent could end up, you could end up having 5 or 6 per one whole-time equivalent.
Right, okay.
So W2TE is really, really important in this information.
Right, okay.
So, yeah.
Well, thank you for clarifying that, Chair, because I didn't know that. All right, thanks. That's good. Thank you.
Okay.
Thank you.
I mean, I have to say, I do think having one immunisations team is safer. It's more robust. It's easier for us to have oversight of. It'll be easier to collect and analyse data. It'll be easier for us to spot gaps in who is taking up immunisations. And it should also help us recruit and attract staff, because there'll be work for a whole team across the whole year rather than these seasonal peaks that we have at the moment where staff come and go. So actually, in terms of a sustainability model, I think a whole team is one team for the whole service is the right way to go. Actually,
absolutely, and I'm quite astounded that there wasn't a whole team before, and it was lots of different groups. I mean, that doesn't make any sense whatsoever. But what do I know?
One of the benefits of integration, Philip, I think, possibly. So, right, I see Kim, and then Luann, and then Jill, please.
Hi, I appreciate this year it's obviously very different circumstances, and I totally agree that an immunisation team is a very good idea. I guess I would just have some concern that you're potentially taking some patients, or maybe a lot of patients, out of their community zone or their sort of maybe area of comfort to get vaccinated, and how that will actually maybe potentially negatively impact the uptake rate. I know that you've put car parking and bus routes and all these things, but it's just, you know, working with elderly people, it can be, in particular, thinking it can be challenging to get people to go out with the area. But I wondered, based on our uptake rates last year, which I don't have to hand, and I'm sure they were shared at some point, as to where we sit in comparison to other cities. Are we, you know, do we have quite a good uptake rate? And I also wondered around this, what about the community pharmacy involvement? Because they certainly give vaccinations, and what was happening with that and how that links in.
So thanks, Kim. So in terms of your first question, so obviously with any change, we need to look carefully for any unintended consequences. So we have been implementing our ongoing vaccinations from our community hubs since a few months ago. So we have been following up every non-attendance to find out why they haven't attended. And actually the location isn't coming up as an issue for people so far. So hopefully that will continue to be the case, but we'll continue to do that as we go on. Your next question was about data and how do we compare with other places. One of the things we've noticed when we've been looking at improving the immunisation service is that the quality of the data isn't as good as we would like. So we do have some data from last year, but we're not as confident as we would like to be in it. So we've put in place new systems for going, you know, from now onwards in terms of going forwards. But it's really difficult for us to put a lot of weight on previous year's data in terms of comparing with elsewhere as well, because we just do have some questions about the quality of that data. And can you just remind me of your final bit of your question? Sorry, you're on mute.
I can't seem to. Oh yeah, sorry. I can't. My computer's so slow this morning. Sorry. It was just around community pharmacies, because we know that they give private vaccinations on NHS and things, but it's whether they're involved in this at all, or whether expansion to there, just because they're right in all of the communities.
So we have had discussions during this year with community pharmacies, but we decided not to go for that en masse this year because of all the other changes that are happening. Would they have the capacity to support? So they will be doing potentially some mop-ups, and as you're aware, that people can opt to go to the community pharmacy for their flu vaccination, and many people do because it might be more convenient to them. So they obviously have to pay for that if they choose to do that themselves, even if they're entitled to get a free flu vaccination. So that is something we're continuing to have discussions about, and it may well form part of our future plans, but we didn't progress with that, and that was mutually agreed between the community pharmacies and ourselves this year.
Okay, Luann and then Jill.
Thanks. So, two questions, Gail. One's just thinking about workforce, and obviously all areas are going to be trying to look for nurses to do this. Are we looking beyond the nursing workforce, you know, particularly thinking of COVID and having different staff members that can give vaccinations? So that's my first question. And second one's just a little bit further from what Kim was saying. We don't want anyone to be left behind, and we know that there are groups of people, like people where English isn't their first language, or families where there's maybe mental health issues. You know, is there a plan to proactively reach groups where we know traditionally there's been lower uptakes, so that we maximise the engagement levels that we have?
Okay, so I'll take your second question first of all. So in terms of following up all non-attendance, we're doing that, as I mentioned, to find out why. We've aligned one of our public health improvement officers to the vaccination programme as well, and that's specifically to help us to engage with the public, particularly around if there's particular communities or communities of interest that might require a little bit more support to come and take their vaccination. So we're aiming to do that. We're doing that, and we'll aim to continue to do that. Obviously, it's quite difficult, particularly in terms of our data systems, to really get to the bottom of where those gaps are. But that's something that we're really keen and to tackle, and we'll be putting a lot of energy into that. Again, so my memory's going. Can you remember what your first question was again? You're on mute. You're still on mute.
Joanne, you're on mute.
Sorry, sticky button. It was about workforce and whether we're looking beyond the nursing workforce to deliver.
Yeah, absolutely. So workforce is our biggest risk in our mass vaccinations. So there either has just been or is just about to be new legislation covered to allow for a broader range of professions to deliver the vaccinations. I see Jenny Gibbs got her hand up. She's maybe got the answer to that one, but it will allow for a greater range of professions to deliver the vaccinations.
Jenny, do you want to come in on that point just now?
Yes, I can do. Gail's correct. There is a national framework that is just being finalised. It's being finalised through the Scottish Executive Nurse Directors Group currently, and it is going to be looking at unregistered staff and how we would support unregistered staff to be delivering vaccinations. There's obviously, we'll look at identifying a local guideline to support that framework, and obviously look at the education and the governance around that to enable to support that. It's the timing of it. I think it has come out now with a view to the COVID vaccine. I think it's definitely been tight in terms of getting that in place for flu this year, but the process is under. We're doing it just now.
That's great. Thank you.
Okay, thank you. I think I see Jill and then Alison Murray.
Thanks, Chair. I wanted to talk a little about the mass immunisations for flu. I wanted to revert back a little bit to Kim's question around about community spaces, and wondered if there are some particularly vulnerable people who are living within sheltered housing complexes, whether or not it had been explored at any time whether vaccinations could be given at a specific complex so that obviously elderly and vulnerable people didn't have to leave the complex to get their flu vaccination. And my second question was around about large community spaces and mass immunisation. I understand that maybe Highland have been doing this model for a number of years, and I just wondered if we'd looked at them for this practice. Thanks.
Okay, so in terms of your first question, Councillor Sunray, about going to places where people are as opposed to expecting people to come to places that we deliver, that is something that's at the heart of what we're trying to do. We do have in our plans a mobile unit which would give us that functionality. It will take some time to put that in place, so whether or not it'd be ready for this year is questionable, but we will progress with that. And also where we have nursing homes, for example, we have nurses there already, they would continue to deliver the vaccinations as they currently do. In terms of looking at what happens elsewhere in terms of mass immunisations, I'm not aware we've specifically looked at Highlands, but we have been looking at examples from around the world, including Australia and Dubai, in terms of how they do deliver vaccinations safely and continuing during the COVID period as well, and how they deliver them en masse. So we have used that information from elsewhere in the world to inform our thinking about what might work in Aberdeen.
Thanks, Gail.
Okay, Alison.
Hi, yes, thanks. I was wondering about how you identify all the groups. I mean, with half of Aberdeen being eligible, they probably might, the group I was thinking of might be caught up anyway, but carers and also young carers. I know quite a few carers didn't realise that they're entitled to flu vaccines, and I don't know about young carers as well. And my experience, a large, possibly the majority of young carers are not identified as that because they are siblings, and their siblings are often not recognised as young carers by themselves and by others. I was just wondering if anything's been done to try and sort of find that group who won't be followed up as non-attenders because they won't be recorded as such.
So the eligibility for flu vaccination is a clinical decision, so it's flagged up through clinical systems, and that's how people are called in for their flu vaccination. So if somebody feels they should be on the list and they maybe haven't been called, they should contact their GP.
Yes, it's just that most people won't realise, so they their GP wouldn't have them recorded as that. Certainly I wasn't, and I know a half dozen other people, when we had a discussion, none of them had thought to register with the GP as carers, and certainly they wouldn't think to register their children who are young carers as carers with GPs, and so they wouldn't be in the system to be flagged up by the system.
Okay, I think that's something I can probably take offline and discuss with some colleagues about how we could promote that better.
Thanks.
Interesting point there. Okay, thank you for that. John, your hand's up.
Yes, Chair, thanks. I'd just like to make a quick comment on this. I think, I'd like to thank the Chief Officer and Gail for the regular reporting to us at committee and now IJB on this, because I do think it's already a high profile issue, and it's going to get even, well, we can anticipate it becoming even more high profile. So it's right that we're giving this really close scrutiny as we go through this, and we can support officers in the approach. And we've got the mechanics of it here, the capacity, but there's also then the uptake, and then there's the whole COVID thing if it comes through for if and when immunisation. So we're going to be under very close scrutiny. So it's really just to acknowledge that, I think, and I think we'll continue to give it this close scrutiny, but that's all a good thing over the piece. So just wanted to make that comment. Thanks, Chair.
Yeah, I think that's well said, John. In my head, this year's flu vaccination programme is a kind of dry run for COVID vaccinations. So the issues that we encounter, because there will be issues with this new form of delivery and people having to go somewhere other than their GP surgeries. I mean, I've had constituents contact me who've already been in touch with their GP surgeries and been told, no, we're not doing it this year, and are anxious. So we obviously need an information campaign about that. But I think we'll experience the same things coming back to us when COVID vaccination is announced. So we'll learn some valuable lessons from the flu vaccination programme this year, I think. And also our ability to step up the staffing complement. I think Philip's points were well made about actually the modelling and the number of staff that we need, because it is the big risk that we just don't have enough people to do it. But it's encouraging to hear from Jenny that other groups of workers are being authorised to deliver vaccinations. I'm not sure I'd want my cat's vet to give me my flu jabs. I have to say vets are a bit much. Angela, I see your hand.
Given all that yourself and John have said about the importance of this, I wonder if it would be appropriate for the board to get a kind of post-project evaluation on how it's all going, with all the different kind of factors, the whole inequality piece, the public's awareness and the accessibility. So I think we could give a really good cohesive spine to that evaluation, and again do that against the backdrop of COVID vaccination. So I think that would be a good thing to do, to bring an evaluation back, Sarah, if the board was minded.
Yes, it's actually part of the recommendation that we'll get an update report, but I think an evaluation of lessons learned rather than just an update on number of vaccinations delivered. So if we could if we could amend the recommendation to say we'll have an evaluation on lessons learned from the flu vaccination, that would be helpful. And I would expect that we'll see that sort of April, May next year, probably, after the flu. We need to discuss the timing of it. But yes, I agree, Angela. Kim, your hand's still up. Is that from last time, or do you have another point you want to make? No. Kim's steam-powered computer is lagging this morning. Okay, I don't see any other hands, and so I think we've definitely given this a good going over. So thank you, Gail. Thank you for your comprehensive answers to things. As I said, the recommendation is on page 159. So we've noted the updates on immunisation delivery in Aberdeen as set out in the report, and that we're now requesting an evaluation and lessons learned report to be brought back to IJB following on from this year's flu programme. We're all content with that?
Great.
Right, great. Thank you, Gail. And best of luck with it. Really good luck with the programme this year. So that's the end of our business. The next scheduled meeting is Tuesday, the 28th of October, but there may well be a meeting on the 11th of October if we need to discuss finance issues. As I said at the beginning, we'll do our best to give you the 7 days notice of that if we need it, but we might not be able to do that because we obviously need to give the Scottish Government as long as possible to tell us what the financial position is and what our funding is. Well, there's clinical and care governance on the 22nd of September, and there's risk and audit on the 23rd of September as well. And as was clarified earlier, every member is entitled to attend those meetings if they wish as an observer. So thank you all for your attendance and your contributions this morning. It's been really interesting, and we'll see you soon. Bye-bye.
Bye.
Thank you. Cheerio.
Bye, thank you.
Thanks. Bye.
Thanks. Bye.
Thank you. Bye.
Thanks, bye.
Chair.